I'm going to start by with a disclaimer that I'm by no means an expert in machine learning, but I've been trying to apply machine learning into, especially figure out how to implement it in to help with healthcare processes. Okay. So this is trying to give a little bit of a structure to the talk and looking at AI as a cycle that starts with, we have a development of machine learning algorithms. By far, this is the stage where most of the AI activities and research in healthcare has been located. Until more recently, things are starting to move along this cycle a little more now. But yeah, especially in the informatics literature, I would say 99% of the work has been on development of machine learning AI models. And that also includes the idea, usually these are done to get together. So you develop models and then you do retrospective validation with prior data. More recently, we've been hearing a lot of it, especially getting into the mainstream clinical, high impact clinical journals, the idea of, this is no different than other healthcare interventions where once you design those interventions, you need to test them using solid methods, prospective evaluation, randomized controlled trials, and they should be subject to the same rigor as drug trials. And kind of side by side, we also have implementation issues that can go along with prospective evaluations, but also once you have models that work, they have to be disseminated and implemented in larger scales, and that brings a whole range of other issues, which include long-term monitoring of these models to ensure that they remain accurate, and that ties back to development. So I'm going to go through each of these steps, and then for the second half of the talk, I'm going to focus mostly on implementation because that's the part showing a number of examples where we have been using AI to improve healthcare. Okay, so this was, you might be familiar with this report from the National Academy of Medicine. I was one of the co-authors of there's a chapter on AI in the electronic health record, and talking about a wide range of opportunities where AI can improve the user experience with the electronic health record, improve effectiveness, and open up a whole range of other possibilities that were not previously possible or available. And that includes improving the information management. I mean, we're starting to see we could use more intelligent voice recognition system, voice activated systems, for example, to search the electronic health record for relevant information. Also, improvements in user experience. You can imagine visual displays that are guided by artificial intelligence models in the backend that also provide cognitive support. We are seeing, it's including work from our group, I'm going to talk a little bit about this, improvement in clinical decision support reminders and alerts that are filtered based on prediction models. And talking to this group, I mean, of course, access to biomedical literature at the point of care, great opportunities on that space as well. So there's been a large number of thought papers published in mainstream clinical journals, like JAMA had a whole series of articles on AI in healthcare. So I picked just a few to illustrate. I mean, I think they summarize nicely the kinds of challenges we have before AI can actually be used to improve healthcare. So, and this article summarizes the most of the issues I'm going to be talking about. And for example, the idea that black boxes are unacceptable, or the need for transparency in machine learning models, and that by itself is a huge challenge because the first question might be, what do we mean by transparency? And it's quite possible that for a number of machine learning applications in healthcare, clinicians would be completely okay with not understanding what's going inside a prediction. in some situations. In other situations, they might need the justification why a model achieves a certain conclusion. In other cases, transparency might mean help the clinicians with the notion of augmented intelligence. A model is not necessarily giving a prediction, but it might be highlighting trends for a patient who might be deteriorating and just helping a clinician more easily identify patterns. Also, the notion of transparency in terms of regulatory issues. So when a model like this, for example, if it's subject to approval by regulatory agencies, in those situations, a black box may not be acceptable. You might need to be able to understand what's behind that model. Another issue, and that's true for any kind of clinical decision support, is time. If machine learning models, for example, that require a fair amount of data input from users is likely to fail, just like any other clinical decision support system that requires too much effort to use. Complexity, lack of usability, like any other informatics tool. And then the notion of relevance, it has to do with workflow. What stages of the workflow, who are the target users, in what situations a model should be triggered, and how the information should be presented. If a model is not providing additional insights into decision-making, they're likely not going to be useful. And at the bottom, the scientific foundation of the cycle. We talked about the cycle, right? Solid foundation, just like in any other kind of healthcare intervention. So let's take a closer look at each of these stages. The first one, like I said, the vast majority of prior literature in healthcare, especially informatics, has been focused on development and retrospective validation of models. And another viewpoint article that this one focused on stewardship for AI models, and talking about things like, not very different than clinical trials, looking at internal, external validation of algorithms, problems with bias, the need for transparency, reproducibility of models, equity, ensuring that the introduction of models in healthcare will not exacerbate inequities, and long-term monitoring. One of the important points, if you look at the machine learning literature in informatics journals, at least personally, I found all sorts of violations of solid scientific methodology, from lack of scientific hypotheses defined a priori, lack of definition of primary outcomes. People often get into fishing expeditions where you make all sorts of comparisons until you find one that's significant, and lack of adjustment for multiple comparisons. And then on the statistical analysis, not accounting for things like intra-class correlation when using methods such as 10 cross-fold validation, where the samples are not independent, so you can't use a plain simple standard deviation for those, and that way you find significant differences when the absolute difference between models is tiny, and certainly not clinically significant. Anyway, I could go on and on with complaints about these kinds of violations, but that's kind of the gist. Hopefully, I think we're getting better, though. I do want to spend a little more time on bias, because that's something that really is being raised in the literature with pretty important examples. Ruha Benjamin gave the keynote talk at AMIA last year, and she brought up a number of examples within healthcare and beyond healthcare of where machine learning algorithms and just all AI algorithms, statistical models, are used, and a number of models that use, for example, race as a predictor in a way that you're basically introducing systematic bias within the algorithms. And right before her talk, this article came out in the New England Journal of Medicine, showing a large number of examples of models, prediction models that have a high risk of bias baked into the algorithms. This is a screenshot of a table listing those algorithms in the paper. I don't expect you to see the tiny font, but every row here is one algorithm that has a pretty high chance of a risk for bias. Just to highlight a couple of them, you see they listed the tool, the input variables, and quite often they use race, and it's used as a proxy for things like social determinants of health. And there's no biological genetic evidence that race should be used here as a predictor. In all these algorithms raise concerns about, you know, for example, in this first one, a person being non-Black receives 3 more points to the risk score, and that increases the likelihood that a non-Black person would receive better care than a Black person. And the list goes on and on. It's find similar examples here. Another article, this one came out more recently in JAMA during COVID, and one of the quotes that I like is, you know, AI to guide resource allocation is fraught with bias. So we have a lot of algorithms now helping people make decisions about COVID and how you prioritize patients, who goes to the ICU, who stays in the ward, who gets admitted. And many of them using things like race, zip code as a predictor. And those are likely to introduce bias in the decision making. And people are starting to make changes, fortunately, based on this. This is MDCalc. I mean, I've probably heard of it. And many of you have used it. Millions of clinicians use this tool worldwide, and they have a wide range of medical calculators. Currently, what they're doing is they systematically identified calculators that may have a risk of bias, and they put that red disclaimer, and they change the calculation so that race becomes an optional factor, with a disclaimer that, you know, this may not improve the prediction in any way. In terms of, so prospective evaluation, we're also seeing improvement here, and especially with the publication of reporting standards. And we now have Spirit AI and Consort AI. So these are extensions of those reporting guidelines that add, it's about 14 new elements specific to AI to cover, you know, a range of issues that are really specific to AI. And I'm not going to get too much into detail because I feel like I would be preaching to the choir with this group being, you know, such an expert in these areas. But I think it's important to point that out. In terms of implementation, that's at least my impression, you know, following the literature, is that we need to spend a lot more time on implementation if ever AI is to become useful and widely disseminated in healthcare. This article brings up a few interesting and important issues. You know, one of them is what I just said, not a lot of attention on how a model that's maybe really well performing in the lab, how we're going to integrate this into healthcare delivery. A lot has to do with workflow. Who's going to use the model, when it should be triggered, for what patients. One important notion is the boundaries of the model. Models have to be designed with a fit for purpose, with a very clear, specific goal. And that doesn't always happen. Quite often it does not happen in the earlier stages of the models, when models are built with a very broad goal in mind, or without any kind of stated goal. Just to give an example of challenges in AI implementation, I think in imaging, we've been seeing a lot of progress in terms of machine learning AI models in a wide range of cases like melanoma. There have been randomized trials looking at diagnostic support for diabetic retinopathy and all these other examples. But let's look at melanoma. So this editorial highlights a number of interesting issues that may come up, a number of questions that have to be asked when applying AI to something like melanoma. So there's been tons of publications looking at fairly decent diagnostic models, detection models for melanoma images. Now, why aren't we using this widely? Well, first question, what is the target population? Who would benefit from an AI-driven melanoma detection tool? For example, there's lack of evidence currently supporting a population-based screening, that everyone should be screened for melanoma like we do for colorectal cancer screening. So second one, targeted surveillance may detect cases earlier in lower cost. But we don't have definitions, evidence-based definitions of who could benefit from an AI-driven kind of screening. And then let's say we have those populations defined. What is the workflow? What is the intervention? Is it supporting total body imaging? So you do a full scan and then apply AI for, is it helping prioritize the images that a clinician would look at? Or is it closed loop? In a completely different use case, would patients have an app on the phone where they can take pictures of their skin and then let a machine learning algorithm run and then advise the patient to seek care, someone to take a closer look? Or would the app actually take a picture, run the algorithm, and then send, do screening and maybe alert providers that a patient needs to be seen? We don't have answers to those questions. I mean, we have algorithms, but the algorithms were not developed with a very specific purpose, and those things kind of need to be tested. You know, the last one is point of care clinical decision support. You can imagine a dermatologist or someone with less training being guided by an algorithm that highlights the images that they should look at, and that could improve efficiency. Another really important point that's also now receiving a lot of attention is long-term monitoring. And one of the studies that really you might have seen this, came out on JAMA. And the issue was sepsis prediction models. I know sepsis has been an important target for prediction models, not only machine learning, but also statistical models and all sorts of early warning systems. And prediction sepsis model that's used in EPIC, which is one of the market leads in the EHR systems here in the United States, at least. They, in partnership with 3 health systems, a sepsis prediction model was developed between 2013 and 15, using encounters from 2013 to 15 from those 3 health systems. And then they deployed the prediction model for sepsis alerts to all EPIC customers that wanted to turn it on. And recently, just 2021, the folks from Michigan did an external independent validation of the algorithm using, again, a different health system that was not involved in the original development, and with using more recent data, 2018 to 19. And then guess what happened? There was a significant performance decrease in, you see the area under the curve. The sensitivity dropped dramatically. So 2/3 of the patients with sepsis were missed by the algorithm. And then on the other hand, the positive predictive value was super low. So people were being over alerted in the hospital for sepsis, and the algorithm was still missing most of the cases. So they decided to turn off. We turned this off at the University of Utah. Many people turned off even before this paper came out. So it raises a number of issues. So one of them is the need for external validation. broader external validation. It looks like only 3 systems here was not enough. Another problem, you see the time frame differences. Things change, the prior probabilities, the prevalences change. You know, with COVID, I bet that this model, I mean, we could see even more dramatic deterioration in performance because patients are just so different than they used to be. So this brings a number of questions. How many systems do we need for external validation? Do these models need to be recalibrated at every system where a new population where they are implemented? How should that calibration be done? And also, how should we monitor performance to make sure that whenever we see a drop in performance, what should we do? Should we retrain the models with new patients? And how should that be done? Okay, so now we're going to jump into specific examples just to show. I mean, I raised a number of issues, and I think the picture is a lot of challenges before this can become real. But here we show a few examples where I think very specific targeted use of prediction models, other artificial intelligence approaches can have strong potential to improve care. So let's look at this first one. We are using, so the justification for this kind of work is looking at genetic testing for hereditary cancers. There are estimates that 13% of individuals are at elevated risk for some kind of hereditary cancer. And here in our study, we look specifically at breast and colorectal. Most patients are unaware of their risk. There are estimates that only 20% of these patients have been tested. And there are guidelines recommending risk-based genetic testing based on family history from the NCCN and the US Preventive Services Task Force. So this is an example from NCCN for breast cancer. So you see that it's not easy for a primary care provider to memorize this and apply this systematically to every single patient that comes to the clinic. On the other hand, these data for the family history is being collected. We found that in our institution, at least, medical assistants during the patient intake quite often, ask questions about family history, but oftentimes clinicians don't look at it and don't apply these criteria to decide when to refer to genetic counseling. So what we do in this project is we developed algorithms that scan the patient's family history in the EHR, and then we run the criteria. For patients who meet criteria, we send them a message through the patient portal with a link to an automated conversational agent that includes some AI where they can type open-ended questions. And this chatbot provides education about genetics and why they're receiving this kind of intervention. It talks about the benefits of genetic testing and also the potential implications of a negative or a positive result and other logistics. At the end, the patient is offered the opportunity to get tested. And if they decide to get tested, they'll receive a kit on the mail. They'll collect the samples, send to the lab. The lab will send the results electronically back to the EHR, and a transcript of the chatbot is also stored in the EHR. And if the patient tests positive, well, let's go to the next one. After the results are received and the patient tests negative, they will receive another invitation to go through a post-test chatbot that explains the implications of that negative result. If the test is positive or VUS, then the patient is seen by genetic counseling and potentially referred to cancer risk screening, and that will change their screening practices according to the result of the test. Everything is recorded in the EHR and communicated with the primary care providers who are kept in the loop through clinical recommendations in notes and also the problem list. This is a screenshot of the message patients receive in the patient portal. You see there's a hyperlink that they can click that launches the chatbot on the web. And this is the very final step of the chatbot. It takes about 2 to 10 minutes to complete the conversation, depending on how much detail the patient requests and how many open-ended questions. But at the end, they're basically offered the option to get tested. And like I said, they click yes, no. If they click I'm not sure yet, they'll receive a call from a generic counseling assistant who will talk about their concerns and questions. So this infrastructure is supporting a clinical trial between University of Utah and NYU, where patients, you see that we ran the algorithm against 445,000 patients at the 2 institutions. And we found 22,000 people who met criteria just based on family history, as it is in the EHR. And again, these are NCCN for breast and colorectal. A subset of those patients were randomized between these 2 groups. One group is receiving usual care. They receive an outreach, a call from generic counseling or generic counseling assistant recommending an appointment. And they have a regular appointment with generic counseling. They come to the clinic. And the other half are receiving the chatbot intervention. These are interim results of the outreach. We have about over a half of the people have received that message through the patient portal. About 25% of them completed the chatbot for folks who are in the chatbot arm, and 64% requested genetic testing. And so here are some of the results in terms of the test. So you see that 9 patients tested positive and 37 VUS. The trial hopefully around spring should end. And the whole point is, if there's no, this is a non-inferiority trial. If there's no difference between chatbot and usual care, chatbot consumes much less resources than the generic counseling arm, and allows a larger number of people to be tested and counseled, especially those who test negative. Okay, this is a very different kind of application and different workflow. It's for those of you who know, Smart on Fire is a new interoperability standard that allows extensions over electronic health records. So you basically can develop a third-party apps or a number of third-party apps and use that as plugins in the EHR, and it can be launched within the electronic health record without having to go to a different system. And it basically looks like any other screen in the EHR. This one is for diabetes, and in partnership with Hitachi. So the Hitachi folks developed a prediction model for patients. So again, think about the purpose. This model was designed with the sole purpose of recommending second-line therapy for diabetes for patients who are not responding or not meeting an A1C goal that's predefined here for a specific patient. The algorithm will find the top 3 drugs with a high success rate on top of metformin. So we got 3 options here under different conditions. So you can assume, for example, that the patient might choose to lose weight or add exercise, and then it also, you see the results of the prediction model for each of them. That's the likelihood of this approach helping the patient meet the A1C goal. And it includes other kinds of information. So you think about, this is augmented intelligence. It's not saying, you know, the GLP-1 is the best choice. It's just helping compare and contrast these 3 treatment options, looking at other factors that are not in the model. For example, cost for the patient, and also the comparison of benefits and risks, and more qualitatively. Our clinicians at the University of Utah are actually, this was an unintended consequence, was that they actually like to turn their screen to the patients and walk through the options with the patients, and this kind of became a shared decision-making tool. Very different approach. This is part of work with funded by the National Library of Medicine that we've done about 5 years ago, and looking at how to ways to integrate literature and evidence into the electronic health record. It's kind of an extension of our work with info buttons. So the foundation of this work is that the whole idea is to, when we look at clinical guidelines and other kinds of documents, like in summarized resources, clinicians don't have time to read everything. And so the whole idea was to try to identify sentences that have actionable recommendations. And we define those kind of looking at the PICO framework. So where there's a specific patient population defined in that sentence. There's an assertion like we recommend, we suggest, or we may, and also negatives, we shall not, and also an intervention. Here's another example of the same kind of sentence. So the whole approach is to try to identify those sentences in the first place, and we use a combination of linguistic natural language processing methods along with machine learning classifiers to find those sentences. And then we also used visualization principles to help people to present those sentences to users in a way that they can get an overview of sentences for a specific patient. So this summary here that we see on the screen is automatically generated based on data from the electronic health record. So that's a patient with rheumatoid arthritis. And I want to look at treatment. So I'm going to highlight the main points of this summary. It contains sentences extracted from UpToDate. So we processed the entire UpToDate database and we pre-classified all the sentences in there, trying to find those that are actionable. And down here we have systematic reviews. We use machine learning algorithms to find the high quality, high impact systematic reviews, a combination of machine learning and using some clinical query filters. And same with clinical trials. And we include the article titles, but also try to identify those sentences that follow those, contain those attributes of an actionable sentence. On the left side, we automatically generate these filters, and they're based on UMLS concepts that are found in the actionable sentences. So if I'm interested in treatments, beta-cept sentences, I can click on that filter, and it's saying it has the summary has 30 sentences with a beta-cept. So I can filter and show only those. If I drill down into the UpToDate sentences, for example, it will show all the sentences that were classified as actionable from UpToDate. And I can click on expand to see the surrounding context for that sentence or the entire paragraph. And I can also click on this icon and it would launch UpToDate within the context of that sentence. So we did a simulation study here where we randomized people to use this summary tool versus they just can manual search and use whatever tools they want, but they get no assistance. They use usual methods. And we found a significant improvement in terms of a scale that we created called perceived decision quality that uses constructs such as confidence, learning something new, improving the perceived decision. And with the summary, we did not find any difference in time. They spend the same amount of time with this tool and usual search methods. This, again, very different use case. This is one of our PhD students, Cyril Liu, who's now at Vanderbilt. She leveraged the fact that, we're firing alerts all the time in EHRs, especially medication alerts, drug interaction alerts, drug allergy, drug labs. And there's plenty of evidence out there that clinicians are overriding these alerts massively. It's from 90 to 95% of the time, these alerts are ignored. So the idea here was to try to predict the kinds of alerts in the contexts in which they are very likely to be ignored and possibly should not be displayed, because the chances that this alert is not going to make any benefit are really high. So the algorithms, we looked at 751 features. Those were based on a systematic review done in the literature, looking at all sorts of studies that evaluated alert fatigue and alert overrides, and came up with potential predictors. And the idea was, we don't want to miss any alerts that are potentially relevant. That could be a big problem. So we fixed the sensitivity very much like in a systematic review, right? We fixed the sensitivity very high, and then we try to find the algorithm that gave the best precision, and that was 20%. And even with that low precision, if this algorithm were applied in real patient care, we would cut down the alert volume of alerts that are really highly likely to be ineffective by 54%. So that could have a drastic impact in reducing alert fatigue without running the risk of removing alerts that could be relevant. Again, different use case here in critical care. We funded by the National Library of Medicine and in collaboration with Melanie Wright from Idaho State, we've been doing a fair amount of work on information displays for critical care. And it's really helping people recognize deterioration and then have insights and visualize patterns more easily. So this work from one of our former postdocs, also now faculty at Vanderbilt, where we designed information displays that integrate multiple sources of information in the EHR, labs, vital signs, medications, and display them in trends in a way that help clinicians correlate and make associations and make attributions to patient deterioration. So this kind of display does not use artificial intelligence, but the point here is that just by presenting information in a more intelligent way, in this case, making heavy use of trends and highlighting abnormality, we did a simulated study where clinicians were randomized to use a standard display that's just like in today's EHRs, mostly table-driven. Compared with this one, we found higher diagnostic performance and in less time and higher etiology accuracy for shock. I think the most interesting thing on this study was that, so we had both novices and expert intensive care clinicians, and the novices with this graphical display were able to, their performance matched the experts when they were equipped with this kind of display. So we are currently now funded by another NIH grant looking at how to integrate AI models into visual displays like this. So you can imagine not only a display could show these trends in a nicely way to boost pattern recognition, but you could also have AI running here where we could find a patient where there's a prediction for a patient who might be developing shock, and it could highlight in the individual graphs why the model reached that conclusion and what are the parts of the display, the trends where patient might be deteriorating. So you can actually potentially improve the pattern recognition. So again, the idea of augmented intelligence here. Okay, so wrapping it up, there's tremendous challenges before we can have wide use of AI approaches in healthcare. There are research gaps all over the place. In development, in retrospective validation, prospective evaluation, there's a lot of room. And again, I think I'm preaching to the choir here, but methodological rigor is very critical. transparency in prediction models. You know, there's a lot of work on regulation. How do we regulate these models? It's very challenging, especially for prediction models that have to be monitored over time, right? Drugs don't change over time. You have a chemical substance, and it should stay the same. And that's not true for machine learning models. They're constantly changing as the underlying data changes. And also very important that from the ground up, not as an after the fact, that these models are developed in a way that we ensure equity and avoid bias. So for example, in the work we've done with CDS alerts, we deliberately excluded factors such as gender and ethnicity, race, because we had no theory to support the idea that this could be predictors in those cases. In terms of implementation, there's a lot of room for human factors, social technical methods. We have to do workflow, things like workflow analysis to understand how to integrate these AI into healthcare. And ideally, again, this should be taken into account right from the ground up when these models are developed. They should be developed with a purpose in mind. And there's also room for implementation research, implementation science methods to figure out best ways to implement, deploy models and disseminate them. And then finally, methods for monitoring, for localize models. Do they have to be retrained with local data? Do they have to be calibrated? How often do they have to be updated? And what are the methods that have to be implemented to continuously monitor and update those models? And that was my last slide. Thank you.
Great, thank you very much. I appreciate the range of applications that you've shared for us to consider as well. We certainly have some time for questions. Is there anybody in the group? Feel free to either raise your hands or we can use the chat function as well. Okay, I'll kick us off. Oh, thanks, Brian's clapping. The Zoom quiet clap.
Hi, Guilherme. Very nice presentation, very lucid.
Thank you.
Helpful. I'm just kind of wondering what kind of collaboration or training could lead AI into the virtuous state of actually evaluating its claims. It seems to me you need the principles of clinical epidemiology, and that being trained in AI may not include that. So maybe there should be training of AI specialists in evaluation. If they're going to be involved in applications that they hope will change the way people do things and for the better, then they should actually have as a compulsory part of their training enough clinical epidemiology to know the difference between adequately assessed and not adequately assessed. Or you could wave a flag and ask clinical epidemiologists to start looking into AI so that you've got some independence of the evaluation. I think it's a big problem for evaluators if they actually made the intervention to actually be objective about giving it a rigorous test. What suggestions do you have for how we could get to a better state of evaluation for AI interventions?
Yeah, I completely agree with that. There are many walls that need to be broken to be able to achieve this. I mean, one of them I think is between methodologists, clinical epidemiologists, clinical trialists, and AI folks. And another one is with human factors people, social technical people, and implementation scientists. We need multidisciplinary research and training. in our groups, the examples I gave, I mean, all those projects have people with expertise in all these different areas that I just mentioned. I think that's the only way. Training would help because I think it's critical, because otherwise people wouldn't be able even to communicate. I have a hard time communicating with folks, but over time, you know, it's interesting because I work with folks from, you know, with computer backgrounds in computer science, and over time people start understanding the value of things like, you know, setting your hypotheses a priori, defining your primary outcomes, and other concepts of rigorous research design. But I think it's a combination between education and multidisciplinary research. That's I think that's the most critical.
Thank you.
We have a question in the chat from Weil about the research gap in AI, which are we able to fill most now? Like, where do you see the most potential right now versus where it's most lacking?
That's hard to tell. And I'm going to be biased in my answer because that's what I get exposed the most. So, and I think the idea of designing AI with purpose and with models that are fit for purpose from the ground up, where you are already thinking about an application down the line, and everything is designed to fit that purpose. You know, the study design is influenced with that purpose in mind. How you're going to integrate even the AI methods you use. How much explainability do you need? Is it okay if this is closer to a black box or not? The critical care example I gave is one where we are prioritizing models that are fully transparent and understandable, because otherwise we can't get the outputs of those models and into those visual displays. Other methods might be okay, that they are more of a black box, and you know, you can use the more advanced deep learning methods. So, but those are ideas that have to be integrated right from the get-go, because otherwise it's too late when you get to implementation and then you see that, oh, this model is not providing the information we need for this visual display. We have to go back to the lab in developing those models from the ground up. So I think it would be a very interesting thing is to figure out how to integrate these ideas all the way from the start, when you still have a whiteboard, and think through all these issues from the beginning. I don't know if that's a checklist, or if it's, you know, just like we have the Prisma checklist for systematic reviews. Would we have something similar in the development of AI models, so that AI developers can think through these issues from the ground up?
Thank you. That's actually very interesting. Thank you so much.
Okay, Ahmad.
Hi, thank you, Dr. Fiol, for the great presentation. And let me say hello to Dr. Santia and Dr. Archer. Actually, we are working on the kind of the same project. We are using machine learning for predicting service utilization and severity in mental health in Hamilton Health Science. And we are actually in the phase of retrospective validation. And it was really interesting. I can acknowledge that lack of outcome definition is a big challenge, and we are actually experiencing the same thing. So we have a very broad definition for our outcome. It's like just service utilization and severity, but it's not pretty clear for us. So we have to review all the protocol, and we have to clear and define actually what we are going to predict. And actually the treatment option prediction was very interesting for me, and hopefully we will use the same kind of thing if it's if it's possible, if you can share the presentation with us, that would be great.
Yeah.
Thank you very much.
Absolutely. I'll be happy to share.
There will also be a recording available, Ahmad, that probably within a couple of days. So I can share the link with that as well.
Oh, thank you.
It certainly sounds like if you look at this, you've got a roadmap for your next steps as well. Thinking through all the steps, Ahmad, if you're at retrospective validation, you know where you also need to go. Alfonso?
Yeah, thank you for great presentation, Guilherme, and really fascinating progress. I going back to, you mentioned again the Spirit AI or the construct extension, and you mentioned Prisma and so on. And if I'm correct, I was not aware, I knew of the construct, not of the Spirit AI. They were both on intervention, right? One on protocol and one on trial reporting. And I may imagine they, if they are properly known by ethical board, they have a chance of improving the way research is conducted at that level. I don't know if there's any evidence that after their publication, there was an improvement in quality, and they are pretty recent. I think I saw they were 2020 or so. It might be too early to evaluate. But I was wondering more in general, if there's a ideal step to tackle for educational growth of the community. Particularly, I agree that the implementation phase is late, and the development, in other field is the grant review stage, where you can sort of do efforts jointly with the funding agency to improve the quality of the submission and to make specific requirement and so on. But that usually when you need a lot of money for research, while my understanding is that here, developing and validating on a data set is, I wouldn't say cheap, but is affordable without huge grants. So I struggle a bit seeing how one can plan. I took your point, multidisciplinary group and growing as a community, but is there anything in your opinion that one could target as a preferential step to speed up evidence-based medicine application in this field?
Yeah, and it might be at the development stage. And I'll give an example. This study was not funded by any grants. We had a PhD student who was funded by internal department funds, and her mentoring team included informatics folks, 2 pharmacists, and 1 AI expert. Just a few things we defined a priori through discussion among this multidisciplinary team. We also had a cognitive scientist. It started with the whole defining what is the purpose of this, and from the ground up, we said we don't want to miss alerts. That would be a really bad consequence, and I don't care how much precise this model is. I don't care about F measure, by the way. Sensitivity has to be close to 100%, and that from the ground up already, right? It narrows your possibilities and starts to help target the kinds of approaches you want to follow. And so next, again, the idea of bias. Let's exclude any kind of predictor for which we don't have a theory. We need to have a theory behind this. Let's not just get any kind of variable just because we have computing power and we have approaches that can handle thousands of variables. Let's only look at things that are supported by some kind of theory. And we used the UTAUT model, the Unified Technology Acceptance. I can't remember the entire acronym, but it's basically looks at cognitive constructs that help explain decision making and why a clinician would or would not pay attention to an alert. And then we look for variables that are related to those constructs. So things like years of expertise, expertise with that kind of drug, experience prescribing those medications. We included the context, it's outpatient, inpatient, and but there, again, all the features were used because there was some kind of theory supporting them. And then the primary outcome here, again, sensitivity fixed, primary outcome becomes precision. And in terms of, we did not need a lot of explainability because, I mean, this is very fast, right? It's actually filtering alerts. Alerts are not going to be displayed if they are detected as potentially not effective by the system. So explainability in this case is useless because you're not showing the explanation. You're just not showing the alert to clinicians. So we were okay with a little more black box approach. So all these things were thought through. Having a PhD committee with very little funding, I think these kinds of things could be thought through with any kind of machine learning development with not a lot of cost.
Thank you.
And for this example, because Guilherme, as you were talking, it certainly sounds like there's a role for qualitative research around implementation and understanding what is acceptable and what's not. I can imagine reducing alerts by 54% is very much something people could get behind and appreciate. Has that been something that you've integrated, that qualitative aspect, in the work that you've done?
Yeah, so this PhD work, this was the third aim of the PhD. The first two aims, the first one was a systematic review of studies looking at alert overrides. And the whole idea was to find predictors. The second one was a conceptual framework. So looking at theoretical frameworks, in cognitive science and technology adoption, again, to try to formalize the predictors a little better and guide the machine learning approach so it's less of a fishing expedition. I think that's another point that really, at least for us, I think it really helped. When we got to the machine learning stage, it was relatively easy to develop that model compared to other kinds of studies that I worked on, because we had a lot of guidance in terms of what to look for.
Yeah, thank you.
Oh, another point that we took into consideration as well was to prioritize features that are easily extractable from the EHR, that we know they would be easy to implement, and not something that, this is the University of Utah is the only one that has this feature, or it takes a significant amount of work to extract that kind of feature from the EHR. So that was part of the study as well. We identified a smaller subset of features that, let's say, it's the minimum viable product. If you implement these features, you're going to get that 20% precision without significant information extraction effort.
And that was in Epic as well?
Yeah.
Yeah, it's becoming a dominant player here in Ontario as well. Well, I'm recognizing the time. Thank you very much for, it was really interesting to see the variation in the work that you're doing and the effects. And I think that everybody's probably, I certainly am always learning. It's a journey, I think, as we go into these new areas of research. I'd like to thank everybody for joining us. This is our last one for the year. So happy end of 2021, everybody. And then let's look forward to something joyous to celebrate in 2022. If anybody on the call here has some other ideas, or feel free to reach out to me here at McMaster, because I think that this has been, there seems to be a community of practice around the topic of machine learning in healthcare. And so we could maybe all benefit from understanding what everybody else's needs are as well.